Hello, everyone. Thank you for joining this week's Keck Seminar. We're honored to have to host as our speaker Dr. Dima Suki, the professor and director of clinical research in the Department of Neurosurgery at MD Anderson at University of Texas. There in the Department of Neurosurgery, she oversees a database of over 25,000 neurosurgical patients, and she's very instrumental in the clinical research methodology and regulations that go on there in the research at the Department of Neurosurgery, and where she was also chair of the Institutional Review Board for many years. So thank you so much, Dr. Suki, for speaking.
Thank you so much, Angela, for the introduction. I'm really happy to be here. Can you hear me well? You can? Okay, great.
Yes.
So for today, I tried to select a topic that hopefully is of interest to many of you. I tried to keep it broad. The title of the talk is Ethical Considerations in Research, namely Human Subjects Research, the Modern Data Challenge. I have no relevant conflicts of interest to disclose. The talk objective is review fundamental ethical principles in human subjects research and discuss some of the applications of these principles in the context of primary and secondary research data. So as you all know, we've had a long history of participation in human subjects research, and as humankind, we've tremendously benefited from such research. Traditionally, research serves the primary interests of science, society, and future patients, and less the interests of the participants in research at the current time. Therefore, there is an inherent potential to exploit participants and expose them to unjustified harm. That is, of course, unless we have adequate safeguards in place to prevent harms and to mitigate them when they happen. So as individuals and communities, researchers, sponsors, legislators, any of us, our biggest focus should be to strive to advance research while still protecting human subjects, their rights, their voluntariness, their autonomy, their dignity, as well as their overall well-being. And as you know, well-being is not restricted to physical, there's psychological, there's social, economical, and all. Adherence to legal and ethical standards is essential to safeguarding public trust and participation in human subject research. And once trust is hard-earned, as we know, easily lost, difficult to re-establish when lost. So let's start by a definition of ethics. What are ethics? Ethics is a system of moral principles, values related to human conduct with respect to the rightness and wrongness of certain actions, their motives, and their goals. There are also rules of conduct recognized within a particular group, culture, religion, national origin, etc. Not to say that some of these do not cross boundaries and are standard across the whole globe. So the fact that something is legal does not necessarily make it ethical, and vice versa. It's our duty to distinguish between those two and to try to abide by them both. So the 20th century witnessed the establishment of regulations and safeguards for the protection of research participants and their rights and their safety. And these came along because of atrocious abuses against vulnerable populations. The ones to cite would be the atrocities by the Nazi regime during World War II. And the only silver lining from that is that it led to the first formal code of ethics in the conduct of human experimentation, referred to as the Nuremberg Codes in 1947. And that code is, has 10 different points. I won't read them all. I highlighted the ones that are most relevant to our talk today, but informed consent without coercion, physical and mental suffering should be avoided, participants should be protected against even remote possibility of harm, and human subjects should be free to end the experiment at any time. Unfortunately, abuses continued, including in the US. So we had more rules, more regulations, and currently we have a large body of rules and regulations to abide by. Some of them are national and federal regulations. I cite a few here: the Belmont Report, which is the cornerstone of ethics in the conduct of research. We will get back to that in detail. There is the Federal Policy for Protection of Human Subjects. Some of you may have heard of it. It's referred to as the Common Rule because multiple federal agencies have adopted it. There's the Food and Drug Administration, the FDA, which deals with studies on drugs, devices, and biologics. And one reason the FDA is relevant here is because we have devices are considered any article, whether it's a true physical article or something else like an algorithm that can be used to diagnose, to mitigate, to prevent, to treat a certain disease or condition. And in many cases, as you know, these days there are AIs that are used for those kinds of functions, so they would fit under the device definition of the FDA. Another federal regulation that's important and is relevant to our talk today is the Standards for Privacy of Individually Identifiable Health Information, also referred to as the HIPAA Privacy Rule, and we'll get to that a little bit later. There are state regulations that are in place. There are institutional policies depending on where the study is being conducted, and studies cross boundaries or borders as well. So there are international guidelines. Some of them are like the SIOMS and WHO international guidelines, the good clinical practice, and there are privacy regulations, some of which are even more widely encompassing than the HIPAA regulation in the US and don't just cover medical information, but beyond that. So always the stricter laws apply. So we have to keep that in mind. If the state regulations are stricter than the national ones, then the state regulations would apply. Going back to HIPAA, HIPAA is the Health Insurance Portability and Accountability Act, and it provides national standards for the protection of personal health information. What it does, it limits the access, use, and disclosure of protected health information. It requires patients' authorization for disclosures of such information outside the covered entity, which would be the place where the patient is getting treatment or any health-related service, and affords patients the right to get an account of PHI disclosures. There are 18 identifiers under the HIPAA law, and this is a list of those. If we look at them, some of them seem really reasonable: name, social security number, address, driver's license. All these are indeed identifiers, but there are some others that we may not think of. For example, the last one I highlighted in red, any other characteristics that could uniquely identify the patient. And in some cases, it could be when we record the participant's voice is an identifier, which we may not think of. It could be that the participant has a tattoo or a birthmark, which if we're taking pictures and these apply, that could be an identifier. It could be a lot of things. Handwriting, if you're doing a small study with a group of individuals, handwriting may be an identifier. From the top list, something that people always forget is an identifier would be dates like surgery date, discharge date. And this is because in combination with other variables, such dates could potentially identify an individual. So for data to be considered de-identified, all of the 18 HIPAA identifiers must be removed from the data set. So it's not an easy task often to de-identify a data set. What happens if there is an unauthorized disclosure or breach? First, let me define them. Unauthorized disclosure or breach, they're not the same basically, but these are instances where identifiable information about a research participant becomes available to unauthorized individual, regardless of what caused it. Unauthorized disclosure could be the data and the identifiers going to someone in the same department who is not supposed to be seeing this information. That's still an unauthorized disclosure, but it may not constitute a breach. So a breach is a higher level, and a breach is reportable to federal agencies, like if data goes out via an outside email and gets into the wrong hands, that potentially could be a breach. So going back to the Belmont report, which describes the 3 most important ethical principles in research, I mentioned here respect for persons, beneficence, and non-maleficence, and justice, and I will talk about each one of those. Respect for persons means we need to recognize personal dignity and the autonomy of individuals and provide special protections for individuals with diminished autonomy. Those with diminished autonomy are also referred to as vulnerable populations, and the first that come to mind, I'm sure you all think about them, children, pregnant women and fetuses, prisoners. These are actually part of the common rule. They have their own subpart within the rule, but there is a whole slew of other types of population that would be considered vulnerable, such as individuals that have low socioeconomic status, those that are impaired one way or the other, like those mentally impaired, some minorities like race, religious groups, sexual orientation. Sometimes employees may be considered vulnerable if a study is being done on employees within an institution, and the data could be sensitive and impact their employment status or evaluations or other. So it's very important for us to keep this in mind as we do research. Under respect for persons, we have several concepts. The first one is autonomy and capacity to understand and consent, because again, individuals should be participants in research, understand what they're going into. So that's achievement of truly informed consent. Just reading a consent form does not necessarily mean they're truly understanding. So we have to make sure that participants truly know what the study is about and what the tasks are involved, what the risks and benefits are before they sign on. Assessment of competence to make decisions. Again, we need to make sure that whoever is making a decision is competent enough to make that decision. The second concept is voluntariness, and participants have a right to know and decide what is being done to them, their bodies, samples, and data at any time and for exactly what purpose. And they may decide that what's being done in the study is not what they would like to subject themselves to, therefore will not sign on to the study. They have the right to decide what can be shared and who it can be shared with. The regulations allow, in some cases, for some waivers of informed consent and authorization, which is related to HIPAA, but there need to be adequate justifications that the law requires before such waivers of authorizations are given, and it has to be the appropriate body granting these authorizations. Disclosure is the third concept here, and patients have the right to know whether results will or will not be shared with them and placed in their medical records, for example, if this is applicable. Implications of research, they have the right to know that implications of research may be unclear. We may have results that are not actionable, and potentially we may not share with them for that particular reason. That not all conditions are curable or even treatable, and that there may be obligations to report certain findings. For example, if during the course of research they find some activity that is under mandatory reporting requirements, that they would have to report. And if data and samples may be used outside the scope of the research. So A key concept here is that consent must be ongoing. We don't just do it at the beginning of the study, but as there are changes to anything in the study, whether new risks emerge, whether procedures need to be changed or any of that, the consent has to be redone, and participants will have the right to stay on or leave the study. The second very important concept under the Belmont report is beneficence and non-maleficence. And that relates to risk versus benefit. So the goal and obligation of research is to maximize the benefits to participants while minimizing the risks to them. So we need to, first, as investigators, we need to identify the risks specifically associated with the research and the factors that lead to them where known, because some risks are not known, and therefore we can put them there. But we should put a statement there that not all risks are known, if that's the case. Ensure that the risks are minimized, that there are alternatives, meaning there are other options for people to take other than what's offered in that study. Safeguards in place to prevent any harm, and remedies that if harms actually occur, there are ways to mitigate them. We need to make sure that risks are reasonable in relation to the anticipated benefits. And importantly, going back to the autonomy and respect for persons, we want to make sure that participants are adequately informed in advance about any reasonably foreseeable risks or discomfort, so they can make the right decision for them. So, interestingly, the only definition of risk in the Human Subject Protection Regulation is that of minimal risk. And the regulations define minimal risk as the probability, meaning how likely, and so the end is important, the magnitude, how severe. So it's the probability and the magnitude of harm or discomfort anticipated in the research should not be greater than those ordinarily encountered in daily life or during the performance of routine physical or psychological exams or tests. So you can take an example of something that is very highly probable, but the magnitude is not severe at all, then that would not be more than minimal risk based on this definition. The same thing, it could be something that is very unlikely, but when it comes, it's very severe. And again, because of the end, this would not be more than minimal risk if it's going to be so rare that that event happens. And again, these are all study specific and have to be looked at carefully every time. So I ask you this question: how much risk is justified by the intended benefit? Is that, do we have a rule for this? And the answer to this is there is not a one-size-fits-all answer. Based on this, is it ever ethical to conduct a study that offers no potential benefit to participants? And the first thing that would come to mind, likely if I were to ask you, and I've asked other groups before, the first answer would be no. But actually the answer is yes. In some cases, that it may be no added risk or only a minor increase in risk in the study over what's expected outside the research complex. So it's a very minimal risk study. Participants are not going to benefit, but there will be potential benefit for future patients or participants. So it is ethical to conduct such a study. Pending other, like we have to look at other issues, of course. The second question is it ever ethical to conduct research that holds significant risks to participants? And again, the first thing we can think of is no, of course not, significant risk to participants. Why would we allow this? Well, in some cases, let's take examples of individuals who are severely sick and have an almost certain death from their disease. In my department, we deal a lot with brain tumor patients who have only a few months to live based on expectations, and there could be an effective, a potentially effective therapy, and so they would want to sign on to the study, although the risks may be high because there could be direct prospect of direct personal benefit to them from getting on that investigational therapy. So let me give you a couple of definitions, or they're not real definitions yet, but like some relevant concepts. Privacy first, it's a legal human right upheld by federal and state regulations here in the US and in many countries externally. Confidentiality is an agreement made with research participants, and again, I'm talking here only in the context of research. An agreement made with the research participant, typically with the informed consent, and that meets applicable regulations and policies. It relates to the identifiability of research data, where it will be stored, who will have access to it, how long it will be kept, and those kinds of things. Sometimes those two terms are used interchangeably, but typically privacy pertains to individuals, the privacy of a given individual, and confidentiality pertains to data. So I hope you would agree that individuals have a right to both privacy and confidentiality, meaning they have to have control over the extent, timing, circumstances of sharing information about themselves. So, but that unfortunately doesn't always happen. We may have violation of privacy or breach of confidentiality, and these could happen within research as a result of different things. First could be as a result of actions that the researchers could have mitigated and should have. For example, they didn't plan well methods of participant identification, recruitment, contact, the consent itself did not provide the required information. So individuals feel that once they get the questions, they feel that there was an invasion of privacy. Research setting, I'll show you a slide after this about what I mean by research setting. Staff education, training, and vigilance is very important. Sometimes staff don't even know what is considered an identifier, like I discussed when we talked about the 18 HIPAA identifiers. Type of data collected, data collection methodology, data storage, access, and sharing. So these are typically more obvious and can be mitigated. In other cases, these are less obvious and less controllable situations. For example, and we're getting into more of these situations these days, difficulties in distinguishing between public and private behaviors and settings. For example, internet chat rooms, is that a public versus private? A lot of individuals taking part in chat rooms or having Facebook accounts may think that there is an expectation of privacy there, but that expectation may not be real, or the privacy may not meet their level of expectation. Another example I can give you is if we draw, for example, on public that notices to contact the surviving relatives of individuals who committed suicide. Those relatives may feel that there was an invasion of privacy there, although we are utilizing public records about the death of these individuals. So sometimes there are a lot of nuances and we need to be familiar with. Cyber attacks and theft, which are becoming a bigger problem these days, these are less controllable situations and could impact privacy and confidentiality. This is an example when I was talking about the research setting. So the questionnaire could be a very valid questionnaire, asking a very important question, but if it's asked within this kind of setting, that would definitely be an invasion of privacy for that particular individual. What happens when there is a violation of privacy or a breach of confidentiality? Well, we have a lot of different types of harms that can come out. Financial, economic harm, for example, loss of employment, loss of insurance coverage. And some laws have come up along the way to address these. For example, the GINA law, the Genetic Information Non-Discrimination Act in 2008 to prevent discrimination based on genetic information as far as employment. There is social harm, stigmatization of individuals or whole communities, example, sexual minorities. There could be criminal and civil liability when there is disclosure of illegal activities. Some of them are not necessarily reportable, like the smoking in a minor or alcohol use in a minor, but others do, like child abuse or immediate risk of harm to self or others. So individuals need to be educated in advance that if such things are noticed, they are reportable. There is risk of harm to others. And again, I want to mention that the risk could be mild or serious and could be transient or long-lasting. But another type of risk is risk of harm to others, like secondary subjects in studies where the primary subject, in fact, provide information about others. Like when we talk about Facebook posts and someone will go in and talk about his or her mom having cancer or having a problem with drug abuse or any of these issues, and identifying that individual. Physical harm, one example would be studies of gang or domestic violence. So if someone who is in a gang or domestic violence is participating in a study, then that disclosure, knowing that someone is participating, automatically identifies that individual as being part of a gang or like doing a perpetrator of domestic violence. And so both the participation in the study as well as the actual data collected during the study need to be kept confidential in such a situation. Emotional or psychological distress, again, it could be related to the research question itself, like questions about feelings about death in someone who is very close to death, issues with the instruments, interview questions not being well validated or sensitive enough, the staff themselves not being adequately trained. But the emotional psychological distress can come as a result of violation of privacy or breach of confidentiality, and can come from any of these previous harms that I discussed. If there is loss of employment, that could also cause emotional or psychological distress. And there are other unintended consequences. The third and last Belmont report principle to discuss would be justice, which is the benefits and risk of research should be shared fairly and equitably among different types of individuals. When we say equitable selection, the first things that come to mind would be race, national origin, language, gender, age, socioeconomic status, educational level. And I don't know if you're familiar with clinical trials, but one example from my world is often early clinical trials would exclude children, would exclude pregnant women, and even elderly patients from participating into studies. And the impact of this was that the results of those trials could not be generalizable to these individuals. And that is because diseases sometimes behave differently in different groups. So that's something to keep in mind. No population should be deprived from the benefits of research. Alternatively, there were many studies done, particularly in the past, unfortunately, even now at times, where some vulnerable groups, because they don't have the autonomy to make a choice, they sometimes are enrolled on high-risk studies. They are coerced to enroll on high-risk studies because no one else would if they had the choice. Examples of these would be prisoners, for example, or certain races. There is a very famous example here in the US, which is the Tuskegee study. And if you haven't heard of it, I would urge you to go and learn about it. It's been the basis of a lot of the guidelines and regulations that we've had since that time. There also needs to be equitable compensation when compensation isn't. Now, one thing that I want to talk about is, traditional research methods have always been face-to-face type studies where people come, there is an intervention, type design, or they may do a focus group, face-to-face surveys, interviews, whatever. Other types of things where collecting samples, doing some type of analysis, collecting familial pedigrees for genetic analysis. These are regular things, or using secondary data. But the secondary data we used to use, and by secondary data, I mean data that was originally collected for a purpose other than that particular research, but is now being used for this research. So secondary data always existed, but it used to be very limited. We would look at medical record data within the same institution, demographic data, and that's typically the extent of it. Well, we are no longer in this world now, and as you can see, we have a lot of novel research methods and settings. We have mobile apps that people can collect data from, wearable technology and sensors. Social media is a whole new world by its own. Chat rooms, clinical decision support software, machine learning algorithms, and artificial intelligence, which again, as I mentioned before, these bring an important point of being devices, which means they could be under the purview of the FDA, which a lot more legal implications, virtual reality. There's also a lot more, like we still have face-to-face research, but a lot of research is now conducted virtually, including for clinical trials at time. A lot of tasks are done virtually and via clinical and research platforms. And I want to say that this didn't start with the pandemic by any means. We did have a lot of these for a few years now, but the pandemic certainly helped, and now a lot of what we do is virtual when we can. And the last one I want to mention is the big data concept. And so, as you can see, with the traditional ones, we had a better handle on the risks and even potentially the benefits. With the novel research methods, especially when we're talking about social media, we're talking about the machine learning algorithm, artificial intelligence, about the big data concept, the risks are less obvious, less well-defined, less quantifiable, less predictable, and therefore a lot more challenging. So going to big data and data science, as you know, there is at this time an incredible amount of information going freely and openly on every individual. Just go Google yourself and you'll see what's available out there. Also, data production, availability, storage, processing, and dissemination have changed more dramatically in recent years than arguably any aspect of human society. I remember the days, I'm old enough to remember the days where we had a floppy disk entered into the computer. So it's mind-boggling to see how far we have come and how far we're going each and every day. So that brings the concept of big data, which is interrelated to data science. And these are the collection, preparation, analysis, visualization, management, and preservation of large collection of information that have been collected for various purposes, totally unrelated at times, from various sources, again, totally unrelated, and that they would include anything you can think of on a given individual: demographics, medical records data, omics data, imaging, social media platform data, phone records, cloud system data, the photos we collect and gather every day, any searches we do on the internet, etc. All of these fall under this umbrella of big data. The exciting part is that we can put all these together. The scary part is that we can put all this together. So as you can see, information risk is ubiquitous and is growing. We have many new types of identifying elements being introduced. There is perpetually increasing capacity for the identification of a presumably de-identified data set. Initially, in the past, we used to remove those specific identifiers, and here we go, we're good. Now, we are collecting so much information so that we can very easily identify a patient by the unique set of rows, because we have so many columns in our file. Each individual can be identified much easier. So just the sheer volume of elements collected and downstream data linkage. We also have more and better types of matching tools and algorithm and powerful machines. So these are also helping, and these are also becoming better and better every day. So the de-identification standard is a moving target. What's considered de-identifiable today, tomorrow may not be de-identifiable. And for this very same reason, the common rule, which is the federal regulation governing human subject research, in the latest iteration said that they will be reviewing the de-identification standard every 4 years to see if there is a need as to what can be considered identifiable or not. At this time, the HIPAA standard is higher than the common rule standard, but eventually that the common rule one may catch up and even exceed. For example, let's say the whole genome sequencing becomes an identifier on a patient. There are issues of data security that are emerging. There is difficulty restricting access to data for all the reasons I mentioned before, and lack of control over data flow, where and with whom the data that we started with, somewhere, somehow, where it ended up. So going back to the definition of minimal risk that I shared with you before, you can imagine that the risks encountered in our daily life are changing daily, and therefore what's minimal risk needs to also be revisited frequently. So going back to the respect for persons and trying to apply those concepts to these novel methods and settings of research, most participants can usually judge for themselves and should usually judge for themselves the degree to which they choose to reveal information about their persons and their lives. I remember days when the word cancer was taboo, no one needed to know. Now I see so many people in different age brackets just posting about these diagnoses on Facebook or elsewhere, and that's perfectly normal at this time to them. However, one important thing that individuals need to know, or one important thing is they have they can judge, but they have the right to make an informed decision and a voluntary choice to participate in research, following full disclosure by researchers of potentially and reasonably foreseeable risk, as well as the timely disclosure of new one. And do we have that? Are we offering this to participants in this new day and age in those non-traditional settings? In the traditional settings, again, we have control of and oversight of methods and setting, recruitment criteria. We can exclude or safeguard vulnerable patients with attention to not exclude unfairly certain groups or individuals. We can have adequate ongoing consent. We know what's in there. We know where the data is going, etc. We can disclose research results if applicable, and participants have the chance to withdraw from the study if they decide that the risk to benefit ratio or is not good for them or for other reasons. As far as autonomy, capacity to understand and consent, unfortunately in novel research setting, let's say social media type data, the length and complexity of the user agreements on various platforms is prohibitive. There are challenges to individuals with low literacy. Often there are no optional tasks. You're either on Facebook and you sign our policy or you're out. So there are no nuances there. There's underestimation or ignorance of potential risk. Often people don't know that when they're on an app, for example, that their location can be tracked, although location has nothing to do with the study at hand. And that could potentially put them at risk, depending on where they happen to be and if they weren't supposed to be in a certain place. There's lack of clarity on data ownership. So are we achieving truly informed consent by utilizing these kinds of data as sources of data for research? Assessment of competence to make decisions, lack of necessary checks and controls. Do we know the people are really who they say they are? And if they are the person who they say they are they providing the correct information, whether it's age, race, gender even, or other information? As far as voluntariness and disclosure, there is a frequent lack of clarity at the outset related to potential sharing and future use of data and identifiers, because data has a life on its own in this day and age. There's no return of results and how the data was used. There's no ongoing consent, and there is limited ability to withdraw consent. Again, once the data is out there, it's out there. We often cannot get rid of it. In the traditional settings, as far as so we talked about respect for person. Now we're moving to beneficence versus maleficence. Again, in the traditional setting, we could use sensitive tested instruments. We could do appropriate staff training. And if people ended up having problems, we had adequate and timely referral and planned resources. I see someone's hand up. I'm going to continue unless you want to pose your question. And then there is close oversight. Unfortunately, so this is not easily applicable in novel research settings for reasons I'm sure you can deduce yourself. As far as privacy and confidentiality in traditional settings, we had control and oversight and methods and settings again, collecting only the minimum amount of information necessary to answer our study question. We were required to delink data from identifiers and secure the master key or anonymization, restricting access, maintaining the data and identifiers in a secure environment, requesting a waiver of consent documentation is appropriate, or obtaining a certificate of confidentiality. And you may or may not know what a certificate of confidentiality is, but this is basically a certificate that studies that are funded by the NIH get automatically, but other studies can request as well. And this protects against forced disclosure of sensitive information to federal, state, and local authorities. So if someone is doing a study on something sensitive and they get a COC, then there is no one can force you to disclose. You can voluntarily disclose the data, but you would not be required to. This does not impact mandatory reporting aspects, which are a few areas, but it does impact all. So as we see with privacy and confidentiality, we can do more in traditional setting, but these are not necessarily easily applicable in novel research settings. So some may argue that easy safeguards would be anonymization, and I want to make a clear distinction here between anonymization and de-identification. Anonymization means you are not able to re-identify no matter what you do. It's totally de-identified, totally anonymized data, versus de-identification means the data itself doesn't have any identifiers, but there is a key somewhere that will allow me to re-identify. And people should not use these interchangeably because there are legal and ethical implications to these. The federal rule defines human subject as someone who, on whom we obtain information or biospecimen through intervention or interaction, or on whom we obtain identifiable private information or identified biospecimen. So if for nothing, the issue of de-identification versus anonymization would impact whether someone is truly considered human subject under the federal regulations and whether the rules apply to that individual. So the downside to anonymization, which again, some people may think it's the best thing, is first it reduces the benefits. It precludes the ability to link databases and types of data together. Not long ago, we always wanted to de-identify and anonymize because we felt that this protects patients. But now we know that if we link data from various sources, we maximize its utility, its potential. It increases the reach of research funds, promotes innovation, speeds up research discoveries. So we would want to not anonymize data, but we want to safeguard it. And it also limits the ability to communicate actionable valid findings. If the data is anonymized, we wouldn't know who the person is or the group of individuals are to return the research results so that they can actually have actionable findings or act on these findings. Oh, not to say also that, which I alluded to before, that it's very hard, if not impossible to achieve, especially nowadays. An interesting fact I thought I would share with you here is that 87% of Americans are apparently identifiable based on a combination of zip code, birth date, and gender. So but you may come back to me and tell me, well, the zip code and birth date are not are identifiers under the HIPAA regulation, but I would answer back that even without any of the 18 HIPAA identifiers or whatever other non-identifiers, with the sheer number of data that we have, we will be able to identify a lot of individuals in a supposedly totally de-identified data set. The one important thing, and I would like to mention here, is that norms are evolving, which further complicates the picture. Evolving norms associated with information risk and informed consent. The very notion of privacy is changing, as I mentioned, sharing, diagnosis of cancer or other types of thing online. The standards of what's reasonable expectation of privacy or what's public versus private behavior is also changing. And there is also, again, a change in what's a risk and what's a benefit. There is an increased perception of benefits to human subjects, science, and society by safeguarding identifiers of data. And there is more acceptance and expectations of data sharing. Now, it's important to at least for me, and maybe hopefully for you, that there are costs for underestimating risks, and it's all those harms that we've talked about before, but there are also costs for overestimating risk, right? So the balance is hard to strike. If we overestimate risk, we're slowing down the research, we're compromising scientific quality, validity of the research, we're putting unnecessary barriers essential for understanding every aspect of our human life, right? So we want to be to try to strike a balance. It's important to distinguish between this participant may face in their daily life versus those strictly resulting from research participation. It's important to establish to look at established and current scientific knowledge, get professional community expertise, and when making decisions about risk versus benefit in a specific group or community. And lastly, as it relates to regulations, as I mentioned early on, there is a whole body of regulations and guidelines covering human subject research, and these have provided a strong framework against the known historical challenges that we face. However, things have changes. The novel methods have brought new challenges to the current rules and regulations, and those regulations have unfortunately not kept up. These challenges are for individuals, they're for communities, and beyond. So there is a pressing need to review and expand applicable regulations and ethical safeguards to cover these novel landscape. And my last slide would be there are other issues as well with those novel techniques. Some of them are data misuse. So the ability for us to access or collect data does not mean we automatically have the right to use it, nor does it make such use an ethical use, right? So individual data is often used in a secondary fashion for purposes beyond the original reason that it was intended, and this is often a violation of individuals' privacy. So you may be doing a study that is fully ethical, you've gotten all the required approvals that you need and everything, but the original way the data was collected was unethical to start with. So does that make your work unethical? This is food for thought. The second aspect, especially related to big data, is data accuracy and validity. In traditional methods, again, we have quality assurance, we have limited data, so we can check it, verify it. How do we know whether the data that we're collecting now, gathering under big data, is accurate and whether it's valid? Are we introducing types of biases and how are these impacting the accuracy and validity of our results? A lot of the data that we're coming up with at this stage are no longer just impacting individuals, they're impacting society as a whole. So this is very important to think about. I forgot I had this one extra slide about justice. As far as equitable selection in these, remember, older individuals and disadvantaged populations may not be equitably represented in things like social media and other types of things. So is there adequate representation and what biases do these introduce? So as take-home points, the rights and safety of participants are not to be taken lightly. Various uses of data carry real and fast evolving risks. The well-being of individuals and communities stem from protecting their rights and safety while enabling beneficial research and removing unnecessary roadblocks. Legal and ethical frameworks addressing these issues are needed. These are some useful readings for you if you're interested. And I leave you with this quote that I absolutely love. How far you go in life depends on your being tender with the young, compassionate with the aged, sympathetic with the striving, and tolerant of the weak and strong, because someday in your life you would have been all of these. Thank you so much. I hope this was worth your while, and I'm happy to answer any questions.
Thank you so much, Dr. Suki. Okay, sorry for the echo. There is a question in the chat about our time series physiologic data, e.g. 7 days of seconds by seconds heart rate monitoring considered big data? And if yes, are there different issues with respect to ethical handling of such data?
Okay, so it's a great question. Thank you. So big data relates to a number of aspects. So the fact that you have a big data set because you're having a 7 day second by second heart rate monitoring speaks to the volume of the data. But it's not just the volume that matters. It's also, is there sharing of data? Like, are you combining the data set with other types of data? and all other considerations. So if you are collecting physiologic data under one protocol within one institution, and you have all the ethical and legal issues taken care of, it doesn't really matter whether this is big data, you've covered all the ethical requirements. So the concerns that I was bringing about big data is when we are combining data sets up with different sources and different types of data sets together to answer a broader question. I hope that answers your question.
Yes, thank you.
Great.
Thank you, Dr. Suki. I have a question. I was wondering about a big part of your presentation touched on the issue of public trust, and that we as a scientific community need to make sure that we're not violating the public's trust by misusing their data. And I was wondering, with large databases, particularly those that are openly accessible, or for example, the database that you work with the neurosurgical patients, what role security plays, and I guess how you can assure the patients that their data will be secure when there's so much hacking going on and when cybersecurity is a big issue.
Okay, thank you for that question, Angela. So as far as the database that we maintain in neurosurgery, this is a database that is under an IRB approved protocol. And for those of you who may not know what IRB is, this is the body that is made charge by the federal regulations to oversee the ethical conduct of human subject research, and they must review and approve all protocols that are considered non-exempt research, meaning that these are protocols that have to be under IRB oversight at all times, and federal regulations oversight at all times. So our protocol is one such protocol. We have submitted and obtained consent initially, but later on we were able to justify a waiver of informed consent for the collection of these data. Our protocol clearly spells out the types of uses for this particular data and who the data can be shared with. Any sharing of this data, if it involves or identifiers or not, would have to go through the IRB for them to ensure that it's approved. If it's going outside the institution, there typically are material transfer agreements or data use agreements that govern the use of these data. So we have information security safeguards to ensure that the data and the way we store it meet the minimum required information security standards. Which some examples of it, that it's stored behind the firewall with access to individuals with permissions. Every access to the database is, there is an audit trail. So all these issues are taken care of. So for those kinds of studies or databases, the risks are smaller. There is nothing that's without any risk, because who's to say that there will not be a cyber attack on the MD Anderson server and the data will be made available to individuals that are unauthorized to get that. But again, it's always trying to minimize any risk. This is different when data is open or public data, and even open and public data is not all created equal. There are open and public data that you can access that have followed from inception all the ethical standards, and there are others that are not. So it's about educating yourself about the sources of data that you're going to tap into to ensure that you are not utilizing data collected via non-ethical standards. And again, this is I mean, a lot of these things are situation specific. So if you have a specific question about a specific source of data you'd like to tap into, I'm more than happy to look into it and answer you or get you an answer if I'm unable to answer it myself.
Thank you. I was wondering specifically about the database that you work with.
Yeah, so the database, if you were interested, for example, tap into that database, you have your own, unless you're rotating totally the identified from our database, you have all your institutional policies. Some institutions would deem it non-subject to research because it's totally identified, with no way for you to be identified, and they will allow you to obtain this information. Other institutions like Dental would require you to have authority regardless and say, I will then that's the decision whether this is subject to research or not, and what you really want to do. If we are collaborating with one of us have that identified ourselves, then the protocol will have to be subject to research. If we are providing you the data and we're no longer getting involved in it, you getting into the identified data that like is non-subject to research. And so it would fall under the federal regulations. And because it doesn't have identified, it will fall under HIPAA. You will not need a consent or an authorization, nor even to justify waivers.
Okay, thank you so much, Dr. Suki. And it doesn't seem like there are more questions, and we're coming to the end of our time. But there are some comments that thanks a lot. It's a very informative presentation, and thank you, Dr. Suki. Wonderful quote to end with. We really appreciate your time and your speaking with us today. And I'm sure you'll get a lot more questions from us by email when we think more about what you've said and how it applies to our work. So thank you so much again, Dr. Suki.
Absolutely. Thank you so much for staying on this whole time. I appreciate it. And thank you very much for the organization. And Melissa as well. Take care, everyone.
Very much, Dr. Suki. And as a